Everyone. Welcome to our Public Health 101 series. Today we're going to be hearing from our HIV and STD surveillance and prevention programs. So if you could introduce yourselves and just share, your working title, so we can kind of give students an idea of the different work we do across the department. So you are good to go. Go ahead.
Okay, thanks, Jennifer. So good morning, everyone. My name is Tom Bertrand. I'm the chief of the Center for HIV, STDs, which is sexually transmitted diseases, hepatitis, and tuberculosis epidemiology. And we're going to just spend, the next hour doing a presentation, an overview of what our center does, and then answering questions. So next slide, Katie, please. So I just want to introduce you first to our senior management team. I'm on the top left there. In the middle of the top row is Dr. Phil Chan. He's our medical consultant. Katie Howe, who's in charge of our prevention programs. Caroline Gummo, who does our surveillance work for STDs, hepatitis, and TB. Guillermo Ronquillo, who's in charge of all of our field services. Lila Batarai, who's in charge of HIV surveillance. And then Erin Fischette, who's our communications manager. And all of them, except for Dr. Chan and Erin, will be presenting briefly on their different programs today. Next slide, Katie. Yeah, so I just want to give, before we start off, a little background on what our center is. So we're within a division called PRIDOMS, which is Prevention, Infectious Diseases, and Emergency Management Services. And so we have 4 centers, and COVID just recently joined our center, joined our division. Our focus, we have about 24 staff. It's a mix of individuals, of epidemiologists, nurses, prevention individuals, field staff, and also policy staff. I lead most of the policy work, and then the senior managers run their programs. And just a little bit more background just to emphasize, we're kind of a unique center in the department. We focus on 4 communicable diseases: HIV, hepatitis, sexually transmitted diseases, and tuberculosis. They're down on the left there. Just as a little bit of background with these diseases, they're all infectious diseases. HIV can be contracted through sex, whether to child or through injecting drug use. Hepatitis, primarily through injecting drug use. Sexually transmitted diseases, sexually, which makes sense. And then tuberculosis, which is an airborne disease. Each one of these diseases are a priority at the Centers for Disease Control and Prevention. And they put out a cooperative agreement for each one of these diseases. So basically each year, every 5 years, we have to write a competitive grant to get funding for it. And then each successive 4 years, we'll write progress reports and reapply for each one of these, which makes it fairly challenging for us. It's a lot of administrative work. The total budget is in the ballpark of $4 million. We do get other funding from other programs in the department, like overdose, a little bit of state dollars, but most of our funding is through federal partners. Just wanted to emphasize before we get into the details, while our funding is disease-focused, our work is very population-focused. From a health equity perspective, the populations we serve are often groups who are marginalized or disenfranchised or have various different challenges when it comes to social determinants of health. HIV is overrepresented amongst communities of color, gay and bisexual men, sex workers. Hepatitis is overrepresented by people who inject drugs. Sexually transmitted diseases is a mix, gay and bisexual men, young people, communities of color, and tuberculosis largely impacts individuals who were born in foreign countries and now live in the United States. So when we do talk about health equity for the Department of Health, I think our programs are a premier group that really focus on health equity and do our very best to overcome the barriers of it. We have a very diverse staff. I'm counting off the top of my head, 5 or 6 individuals are bilingual, and a mix of backgrounds, I would say, overall. Let's see if I have anything else before we move on. Oh, so just a little bit of background. We didn't want to go too far into the weeds of our work, but just have each of the senior managers give an overview of their work from a perspective that will hopefully be understandable for you. And our plan is to present for about 40 minutes. If each person take about 10 minutes. We'll hold our questions until the end, and then we'll have a follow-up conversation. And if there are topics of particular interest, we can certainly have additional calls like this. So Katie, if you want to move on, and I think Caroline is going to start with reportable diseases. So Caroline, I kick it off to you.
Thanks, Tom. Yeah, so I wanted to start by just talking very generally about which diseases are legally reportable to the Department of Health. So in general, the Department of Health, being a state health department, requires by law that certain diseases be reported to us. And that's for utmost protection of the public's health in the state of Rhode Island. But there are varying levels of reportability depending on what the disease is. In other words, some things we can wait a few days to learn about, and other things we need to learn about immediately. So this list here on this slide is a list of diseases which are immediately notifiable to the health department. So as soon as a doctor diagnoses one of these conditions in a patient, they are legally required to report it to the Department of Health. And there are various forms and ways that they can do that. The diseases which are listed in red are what we consider to be highly infectious, highly unusual to see in Rhode Island, or just a significant threat to the public's health. Red diseases include things like measles, rabies, typhoid fever. The diseases in blue are similar in terms of being immediately reportable to the Department of Health, but they're specifically agents that can be used for bioterrorism, things like anthrax, smallpox, the plague. So understandably, if one person in Rhode Island tests positive for one of these conditions, the health department requires knowledge of it immediately, not only so that we can coordinate care for that person, but also we can stop the spread of disease, for people who may be in close contact with them. So both doctors and lab testing facilities are required to report positive results to us, so we get information from multiple sources. Next slide, please. So these diseases are also reportable by law, but the difference is that they're reportable within 4 days of diagnosis, not necessarily immediately. Most diseases, even the ones that we might think of as highly infectious or dangerous, things like HIV, tuberculosis, tetanus, most diseases fall into this category. All diseases that our center deals with specifically fall into this category. Next slide. So those are starred here. All of the STDs, chlamydia, gonorrhea, syphilis, a couple of other more rare STDs, HIV, hepatitis, and tuberculosis, which Tom explained earlier. Next slide. So what is surveillance generally? What does this mean in the context of public health? It's a lot of different things. Primarily, it's counting the number of cases which are reported to us. At the most basic level, counting cases just means, how many positive laboratory results did we get? How many diagnostic reports from doctors did we get? And how many new instances of disease in Rhode Island did we identify and diagnose? As a surveillance epidemiologist at the state level, part of that job is also calculating population rates, determining which groups are most at risk of new disease, where in the state we can implement better resources for testing, treatment, access to prevention, things like that. And so going in hand with all of that is outbreak detection. If we see an abnormal increase in the number of cases that we expect to see for any one disease, we investigate that. We report all of our data to the CDC so that they know what the situation looks like in Rhode Island, and all other states do the same thing so that CDC has a picture nationally of what's going on with infectious disease. And involved in all of that is, of course, ensuring top data quality, making sure that the cases we send to CDC are actual cases, meeting, strict case definitions, and there's a lot of detail involved in that. Maintaining our systems, to report the data electronically and kind of get us into the whole, 2022 working world. Next slide, please. So lastly, this is just a typical trend chart that you would see in epidemiology or surveillance. This one is specific to gonorrhea trends. So this is all diseases related to all cases of gonorrhea reported to us since 2011. The 2021 data is preliminary. It hasn't been finalized with CDC. Every year we go through very strict processes to make sure that CDC and Rhode Island have the same number of cases. But you can get the general gist from this chart. You can see over the last 5 to 10 years, gonorrhea has been increasing significantly in the state. In 2020, the pandemic year, We had a bit of a drop. You can see fewer cases, but that makes sense, right? Because there were statewide closures, people were staying home on the governor's orders, medical clinics were closed, ERs were, focusing more on COVID testing and not STD testing. So this is another part of surveillance, right? Knowing what number, what these artificial changes might look like, knowing that, maybe people in the community do actually have STDs, the same number or even more. We just don't have the means, at that time to diagnose them and report on them. So, all of these things are related to trend tracking and reporting to CDC, and all of it is considered epidemiology and surveillance. And of course, in 2021, you can see that number bump back up, and that makes sense. Things are opening back up, people are getting evaluated again, and there's a sort of return to normal. So those are just kind of some basic epi principles. So with that, I'll pass it off to Katie, and she'll talk a little bit about prevention.
Thank you, Caroline. So today I'm going to start by talking about HIV STI prevention activities. So this is just an overview of all of our prevention activities, and I'll explain each one a little bit more in depth. But on the top left corner, you have our Mask It Up, Wrap It Up campaign, which was promoting our Condoms by Mail program. We have our harm reduction needle exchange program. We do home delivered services, as well as our new drug user health vending machines, which you can see a picture of in the top right corner of your screen. We do free at-home HIV test kits. We have a sexual health app, and then we have testing 1, 2, 3. And this is a lot, so I'm going to go into each of these a little bit more in detail. So our first thing that I wanted to talk about was our Condoms by Mail program. As a result of the pandemic, we started this Condoms by Mail program where an individual could request a package of 15 condoms mailed directly to that person's house. We've sent over 2,000 packages of condoms since August of 2020. We successfully reached some of the most at-risk groups for STDs, people who are under age 30 or men who have sex with men or individuals considered at high risk for STDs. We've reached individuals in all 39 cities and towns, and this fulfilled a need in the community during the COVID-19 pandemic. So prior to us implementing the free condoms by mail, many individuals were receiving condoms either at a federally qualified health center or a AIDS service organization, or we had over 100 locations where we were distributing condoms throughout the state. And then when the closures happened in 2020, we had to come up with creative new ways to get condoms out into the community when people maybe wanted to limit the number of people coming into a clinic, or if you had to schedule an appointment, those sorts of things. So this was fulfilling an unmet need in the community. And then before I get into the harm reduction, I wanted to just start with what is harm reduction. So harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. So it's really important that we meet people where they're at. We understand that drug use may be part of their reality, and we want to provide them with the best support that they need so that they are also not getting infectious diseases if they are injecting drugs. So Rhode Island is a leader in harm reduction, and harm reduction strategies literally meet people where they are. We have a multifaceted approach in Rhode Island to harm reduction. We do street and mobile outreach where we're literally walking the streets, exchanging needles with people on the streets, providing naloxone, and providing other essential harm reduction services. We do door-to-door delivery where anyone can call AIDS Care Ocean State, and AIDS Care Ocean State will drive the services directly to that person wherever they would like them throughout Rhode Island. We are one of the only states in the country that does that. We have new harm reduction vending machines. These only started in December of 2021, and it's a way for people to access services 24/7. We've implemented one of these harm reduction vending machines at the Department of Corrections. We're one of the few states that has that as well, where people who are being released from incarceration can get the supplies that they need before re-entering the community, including naloxone or condoms or any other harm reduction supplies, as well as hygiene kits and other basic needs. And then we have been approved for our Harm Reduction Center pilot program. So a Harm Reduction Center is where an individual can take pre-obtained substances and then use them in a safe environment. for one of the harm reduction strategies that we talk a lot about is making sure not to use alone, because if you're using alone and something goes wrong, then there's no one there to provide services, call for help, provide naloxone, which is a drug that can reverse an overdose. So we want to make sure that people are not using alone, and harm reduction centers can ensure that people have a safe place to use if they are using. That being said, Rhode Island has not yet opened a harm reduction center, but we have been approved through the legislature to start a pilot program. So more to come on that, hopefully, in future months. We saw over 5,740 unique clients in 2021 through our harm reduction services that are funded by the state of Rhode Island. And this was 15,681 encounters. So an encounter can be anything from receiving a bottle of water, or it can be exchanging needles. It could be receiving naloxone. We call them all an encounter because this is what helps develop the established relationship between the people who are receiving services and our harm reduction outreach workers or our peers that are doing this work. This also means that when an individual is interested in seeking care, or if an individual is interested in seeking care, they have someone they can talk to because they have this pre-established relationship with someone who has maybe had a similar experience. And so these harm reduction encounters are really important to develop that rapport and establish that relationship. So our vending machines, we have 5 vending machines currently in Rhode Island. They include safer injection kits, which include clean needles. They have naloxone or Narcan to reverse an overdose. They have fentanyl test strip kits, which test the drugs for fentanyl. Fentanyl being very fatal, and so it's important that if a drug has fentanyl in it, that you use it in a different way or use it very slowly. They have condoms or safer sex kits. There is a sharps container that's co-located with the vending machine. They have wound care kits, including Band-Aids and other alcohol swabs. And then they have hygiene kits, and they provide 24/7 access to these life-saving supplies. And they also tend to attract a younger population than traditional drop-in services because there's less of a barrier to accessing them. So our HIV test kits by mail, we started a project with AIDS Project Rhode Island. They provide pre-test counseling and post-test counseling via phone. We've provided over 500 tests to date through this project, and we're reaching people who have never been tested before, as well as people who feel more comfortable testing at home. This was also a response to the pandemic when many of our drop-in centers had to close, and we needed to figure out a new way to ensure people were still receiving the HIV test kits, even though they were unable to access the traditional services. And then we have our Right Time app. So our Right Time app is our sexual health app, and talks about the right time to access the information that you need about your own sexual health. It has information on healthy relationships, sexual health and family planning services, birth control, prevention and testing and treatment of STDs, how to find free condoms, as well as information on pre-exposure prophylaxis and post-exposure prophylaxis, which are important for HIV prevention, as well as many other things. If you get a chance to check it out, I highly recommend it. You can find it on the Apple App Store or the Google Play Store. And then our latest initiative is Testing 123. So we say that being tested for HIV and other STIs is as easy as 1, 2, 3. And so the testing 1, 2, 3 puts you in control of your health. Step 1, you complete an online form. Step 2, you go to the lab of your choice. And step 3, you get your results and follow up. And these are sent via email or text message. So on the online form, you can indicate which lab throughout the state you'd like to access, and then how you'd like to receive your results. And then if the result is positive for an STD, we give you instructions on how to follow up with a doctor and make sure that you receive proper treatment. And this is done through someone's health insurance. So if you have health insurance, this is a free service. If you don't have health insurance, there will be a cost for accessing this service, and it's encouraged that you call the lab to discuss cost and pricing. At this point, we don't have funding to cover people who are uninsured. So this is some of the social media campaigns that we use to promote testing 1, 2, 3. So part of prevention is ensuring that we get our messages out there. So we have these ads that we're running on Facebook and Instagram. And if you click on the ad, it would bring you to our Testing 123 homepage, and then you could access services there. And the last thing that we do in terms of the prevention portfolio is we do tuberculosis prevention. So switching gears from HIV and STD prevention a little bit, as part of our tuberculosis prevention program, we do screening and we encourage screening of high-risk individuals, but then we also have what's called eMocha, which is a HIPAA-compliant platform to be able to watch people take their tuberculosis medication every day. So to ensure that people are adhering to proper treatment, we have to watch them take their tuberculosis medication every day. And so by using eMocha, they can take a video of themselves so that we don't have to actually go to their house to watch them, or if they're doing it late at night because perhaps of their work schedule. Many people who are on TB treatment are still able to work and still able to be out in the community as long as they're not infectious. So after some initial treatment, they're able to resume their normal lives again. So it's really important for us to be able to have these services so that people can still go about their daily lives. And then finally, we have Uber Health. So access to healthcare and transportation is a big barrier to accessing care and ensuring that you stay in care. So Uber Health is a HIPAA compliant way for the state to request a ride on someone's behalf and to ensure that the person can get to their doctor's appointment and they're receiving proper care. So we can request a ride. The Uber driver doesn't know that the health department has requested the ride, but it makes it such that our staff don't have to use staff time to go and take someone to their appointment. We can send them an Uber instead. So with that, I'm going to pass it off to Lila.
Thanks, Katie, and thanks, Caroline, for describing what surveillance is for us. Now that we're familiar with what surveillance is and how it works, I think it'll be helpful to have a bird's eye view of what HIV looks like in our state. So as of 2020, an estimated number of 3,000 people are living in Rhode Island with HIV, and this is what in epidemiology we refer to as prevalence. The 3,000 number, this includes both people who know that they have HIV, and it also includes number of people who are out there in the community living with undiagnosed HIV. Now you must be wondering how we know about undiagnosed people. And I had the same question when I joined the program 1 year ago. Remember, this is an estimate. And number two, this is derived. We use a CDC formula or code. All of the states around the country do that, which factors in a lot of data points that we already know about HIV, like the number of new cases, the state population, and a lot of other data points that we collect routinely through our surveillance activities. And in the box down below, I have highlighted some major key takeaways from our data. So looking at the last 10 years, on an average, we identify around 73 new cases of HIV per year. Now this number varies every year, obviously, and we had the lowest number of annual cases in the last 10 years in 2020 when COVID hit, just like we had seen a similar trend in gonorrhea and other STD diseases. And in 2020, our cases went down to 51 cases. And when we look at the data by okay, so yes, and in 2021, however, we are back to pre-pandemic numbers. And when we look at the demographic characteristics of in the HIV population, we see some very interesting things. Over the last 10 years, slightly more than half of our new diagnosis is among gay, bisexual, or men who have sex with men MSM population. What is more surprising is that there were almost 3 times as many cases of HIV among the GBMSM population when compared to females, male heterosexuals, and people who inject drugs combined. Based on our data, we can see that the rates of new HIV diagnosis among GBMSM are more than 450 times higher than in heterosexual men. In fact, a CDC study was published in, I believe 2016, that says that the lifetime risk of getting HIV if someone were MSM is 1 in 6 when compared to 1 in 43 in the general population. So that is a huge disproportionate data we see in the MSM population. And when we look at the data by age, the highest number of cases is among people in their 20s, 30s, and 40s. And this trend has remained the same in the last 10 years. When we look at race ethnicity, the rates among Black African American is disproportionately higher. When compared to whites, the rates of HIV were over 6 times higher among Black African Americans and over twice as high among Hispanics, Latinos. Next slide, please, Katie. Yes, so this slide, I am going to touch a little bit about what perinatal HIV surveillance is, or as the name suggests, mother-to-child transmission of HIV. So as you can imagine, the goal of this program overall is to reduce the number of transmission of HIV from mother to child. When physicians or providers identify a pregnancy in a HIV mother, they report that to the department, which is required by the law, as Caroline mentioned in the beginning. We have a dedicated staff member in our team who is a nurse and does the follow-ups with these cases. She coordinates with the cases providers and caregivers, case managers, to make sure that the pregnant mother is receiving HIV care throughout her pregnancy, as well as after the baby is born for up to 18 months or up until we know the final diagnostic status of the baby. In the last 10 years, this has been a great public health success in Rhode Island because we had zero mother-to-child transmission. And this success is largely due to testing of pregnant women and also providing treatment or antiretroviral therapy, that is the HIV treatment when someone is HIV positive as part of the prenatal care. And that is all I have, and I will pass it on to Guillermo.
Good morning, everyone. Thank you, Lila. So I wanted to start off my part with kind of a high-level overview of what we do when it comes to HIV and STD partner services. So as Caroline mentioned in the very beginning, we monitor for reportable diseases, and these newly identified, newly diagnosed cases are reported to us. We make sure that these reports come to us in a timely and accurate way so that we have accurate information and that we know about them soon enough so that we can get our investigations started and control the spread of disease. And that also helps us to analyze trends in the community so we can see how these infections are being spread and where we need to allocate our resources. Part of what we do is also to manage these newly reported cases. We make sure that patients are treated with CDC recommended treatments. This is to make sure that patients are cured in cases of like syphilis, gonorrhea, chlamydia, or that we get them to undetectable levels for HIV. We also locate anybody who may have been exposed to these infections, so sexual partners. We contact them and we refer them for testing and treatment services. So by doing all of this, it's our best efforts to control the spread of disease in Rhode Island. If we can quickly identify positive cases, prevent them from spreading the disease more, and we can contact those people who may have been exposed and get them treated, or in the case of HIV, undetectable, then we can stop even those contacts from spreading the disease further. And lastly, part of that disease control effort is to educate our clients. So we teach them about routine testing. We connect them to different care facilities. We help them reduce risk, and we educate them in the case of HIV on PrEP, which is a daily medication that greatly reduces the risk for HIV. Next slide, please. So I wanted to illustrate what the life of an HIV case investigation looks like. So it all begins with a positive test, right? So someone goes to their doctor, to an STD clinic, and they test positive for HIV. That specimen is sent to the Rhode Island State Lab to be confirmed. And then if it is, we receive a notification that someone has tested positive for HIV in Rhode Island. Our disease intervention specialist, and that is the person who will eventually contact the patient and speak with them. They confirm that the patient has been notified of their status. And a quick notification is very important because we can have that person, before they are engaged in treatment, know that they are positive, and that helps to reduce the spread. And the DIS will also make sure that the person is connected to care. Once that happens, our DIS will speak with the patient. They will talk about their risk factors, last time they tested, what their habits are, and they will also obtain information for their sexual partners. And that is so that we can contact people who may have been exposed to the infection and get them tested and engaged in care if needed. Of course, this is done anonymously. We always protect the information of the original patient, but it is important to contact their sexual partners. Once we have that information, the DIS will go ahead and start calling partners and get them in for testing and treatment. And by doing all this, we hope to intervene in the spread of HIV by linking positive patients to care, and any exposed sexual partners also to testing and treatment services if they do turn out to be positive in the end. Next slide, please. So I wanted to provide a little bit of a case study, I guess. This is a case I worked up years ago. And of course, no names or any identifying information are provided here. But this all looks very confusing, right? And this is how disease networks can look for us, and why it is important to intervene quickly and obtain accurate information. So in the middle there, you'll see the original patient was a 26-year-old male, white, non-Hispanic. His primary risk was he was a man who has sex with men. Tested negative for HIV, positive for syphilis, and positive for rectal gonorrhea. His only symptoms, he had a body rash. He said he had 7 sexual partners. And some of his ways of meeting partners is he used Grindr and Scruff, which are 2 phone applications to meet partners. The person also visited the Megaplex, which is a local bathhouse, and was an adult film actor. So from that initial interview, we obtained 6 names. The 2 partners above, you can see, were notified by our DIS. They tested positive. One had symptom, the other was asymptomatic. And those people were connected to care, so they received treatment for syphilis. The 2 in the middle tested negative. Importantly, because they were still within that exposure period where you can test negative but still be infected, they received preventive treatment. And that is really important, because those people who think they are negative, but it might be a false negative because they're still within that exposure period, we want to get them treated and stop the spread that way. And then lastly, the 2 people below that were named, importantly, and I put the exclamation point there in red, we were unable to locate. We had names and phone numbers and addresses, but we're just unable to locate those patients. And that's really important, because if you look at all the different arrows pointing to them, both of those people were exposed to other partners who did end up testing positive for syphilis, so they were at high risk for an exposure. We do our best to locate anybody who may have been exposed, but sometimes it just so happens that we can't get to them. Next slide, please. So successes, we identified and coordinated treatment for 2 newly diagnosed cases. For each case that came out to be positive, we also did an interview and obtained their partners and tried to get those people into testing and treatment. And then we discussed PrEP with each one of them. And then challenges, like I mentioned earlier, we're unable to locate those 2 high-risk exposures. Next slide, please. Another program that we have in our center is the HIV Return to Care program. And just at a high level, the HIV Return to Care program seeks to identify patients in Rhode Island who are HIV positive and who may have, for any number of reasons, fallen out of care. And our job is to reach out to them, provide counseling, and just try to see what their barriers to care are so that we can help them navigate through the healthcare system, get linked up with a doctor again, and start taking their medications again. Next slide, please. So again, it is a referral-based system. So providers in Rhode Island who see HIV positive patients will send us a referral for someone who they've identified is out of care. Our GIS will investigate, try to find addresses, phone numbers, locating information. If once we do locate a patient, they are interviewed. We try to understand what their barriers are and see if we can help them navigate and reconnect to care. Once that person agrees to go back into care, the DIS will work with them to coordinate an appointment if they need transportation support, anything like that. They'll try to get them back into care and ensure that they make that first appointment so that they're linked up with an HIV doctor again. Next slide, please. I wanted to just show you like the different ways that we find patients. People who are referred to us as being out of care, you can imagine, can be a little bit hard to locate. The doctor has already tried calling, sending letters maybe to try to get them back to another appointment. And so they can be hard to locate. So we look in different places like Facebook, social media, Instagram. We try to find contact information, maybe in the court system. We call other providers that may have seen this person, the pharmacy. I'll just leave that slide up there so you can see. But our DIS really are detectives in a way because we try to find those people who are the hardest to locate and re-engage back in care. Next slide, please. There are many different outcomes, as you can imagine. A lot of times we will find that people just moved out of state and didn't tell their doctor that they were moving. And that's a very easy case for us. They may be in care at their doctor's facility in Rhode Island. And again, maybe they didn't tell their original provider. We are unable to locate some patients. Sometimes they just tell us not to reach out anymore. They don't want help at this point in time, and we do that as well. Or hopefully patients agree to re-enter care and we can make them an appointment. Next slide, please. So one last case study. This is a case that was worked up quite a while ago. During the COVID-19 pandemic, our return to care program was put on pause just because we were all pulled to help with COVID-19. But this was a male in mid-50s, Hispanic. He was followed for, if you can see there, from November 2017 all the way to October 2019. And even then, this person had not been seen by an HIV provider since 2015. Barriers that we had identified to care, just, life, different life circumstances. This person was unable to be engaged with a provider long term. And he also had side effects around the medicine that prevented him from taking them. So in December 2017, multiple phone calls, letters, text messages. We went to the patient's home. Excuse me. We eventually got a call back from the patient, but after that, they kind of fell out of contact with us and they never called us back. All the way in February 2018, our DAS reached out to the AIDS service organization that referred this person, and we found out that this person had been closed as a case due to lack of contact. November 2018, the DIS was able to make contact again. The patient agreed to re-enter care, made an appointment, and then did not show up to multiple appointments after that. So the person never really re-engaged in care. January 2019, the patient went to the ER very sick, and again, makes and cancels 6 visits at the clinic. June 2019, again, another sick visit, not really a visit for HIV services, scheduled a follow-up, did not show up. September 2019, the patient was admitted to the hospital, again, very sick, makes a follow-up appointment, and then finally keeps that appointment and is engaged in care. And up until October 2019, the patient continued to follow up with the clinic and the case was closed for us. But I just wanted to show you that very long list of different attempts that are made. A lot of times we do have contact with patients. They do make an appointment, and then again, life just happens and they're unable to re-engage. But this is why it's really important, even though by January 2019, it might have seemed to us like this is a case that we should just close out. We're not going to get this person back into care. We kept it open, worked with the patient, meet them where they're at, and try to get them re-engaged in care. And I think that's it for me, Katie.
Great. Hey, I'll jump in here. This is Tom again. I just want to thank all the senior managers for presenting. I think one of the things that jumps out at me as I hear about this work is just a reminder at the health department, we're both a local and state health department. So we do all of the work that other state health departments do, but we also have a local responsibilities, which means we're literally on the front lines of working with the individuals in the TB program or STD or HIV or hepatitis programs, which makes our jobs challenging but interesting at the same time. So let me see, and I'll defer to Jennifer on this. I don't see any questions in the chat, but welcome if anybody is on the call that would like to ask a question. Feel free to raise your hand or just jump in. Happy to do that. So I'll give that a moment. And feel free to ask any question of any of the presenters or any topic that you think we might have missed. We'll be happy to answer it. As background, just a little bit, we are in the midst of getting heavily involved in the monkeypox outbreak, I would say, in Rhode Island, because it's new. I think we're up to about 14 cases. So our staff are busy with that these days, doing case investigation, community engagement, data support, and surveillance. So let's see. Jennifer, any thoughts on questions or answers, or should we wrap up?
I don't see any questions in the chat, so we are probably good to wrap up. These will be posted for students at a later date, so they certainly students will probably reach out later if they have any questions.
Okay. Well, thank you very much, Jennifer. If you could send us the link to the recording, that would be fantastic, so we can share it.
Yeah, sure. Thank
Okay.
you all so much.
Take care. Bye now.
Bye-bye.
Thank you.